Hello everyone, I'm the presenter Min-Jie Yang. Today I'm going to give a brief introduction to our study topic, that is the early neuroprognostication for patients with OHCA receiving the therapeutic hypothermia using the 99mTc-ECD SPECT. Let's go through our background first. Since the ascending reticular activating system, or ARAS, is responsible for the human conscious level and integrate the functions of the brainstem with the cortical, cerebellar, thalamic, hypothalamic, and the sensory receptor functions, it is very important in deciding whether a coma patient, especially the coma patient after cardiac arrest, will wake up or not. Many tools have been developed to serve the need for the neuroprognostication in this group of patients, but all of them have some flowback. That is, they may fail to provide an economical and efficient method to demonstrate regional hypoxia insult to the ascending reticular activating system components. In contrast, the 99mTc-ECD SPECT used in our study is highly correlated to the regional brain perfusion. Herein, we aim to investigate whether post-resuscitation ECD SPECT help predict neurological outcome or not. So, we prospectively enrolled OHCA patients with a non-traumatic causes and return of spontaneous circulation for 12 years and performed brain ECD SPECT 7 to 10 days after the index event. Also, we categorized the neurological outcome of these patients with the OHCA CPC score, or the Cerebral Performance Category score. We also calculate a simplified CHOP score as a clinical diagnostic standard for comparison purpose. And for each patient, we give them 750 megabecquerel 99mTc-ECD intravenously, and the mean uptake ratio of each volume of interest were further normalized to the mean count of bilateral temporalis muscle to obtain a background adjusted uptake ratio. Also, for the uptake ratio, we categorized them and scored them according to a logistic regression of the derived probability of the good neurological recovery. Also, we choose the 4 brain regions with the best diagnostic performance to calculate the weighted score reflecting the ARAS preservation, that is the upper brainstem, thalamus, basal forebrain, and the basal ganglia. Okay, here's our result. In the table 1, you can see that on the 179 patients we studied, 33 of them recovered with a good neurological outcome, and the rest 146 showed a poor result. Also, you can see that the patients with the good outcomes were more frequently present with a shockable line upon the rest and requiring low epinephrine doses during the resuscitation, therefore had a significantly lower FCHOP score. In the figure 1, you can see that the EC's uptake ratio of the brain regions were also significantly higher in patients with a good neurological outcome than in those with poor ones. Okay, in the table 2, you can see that it is demonstrate the demographic data and the ECD-derived parameters of the subgroup we study. In this subgroup, you can see that the demographic data is similar to the whole population. Also, we can see that the simplified CHOP score and the ECD uptake ratio in the 4 brain regions with the best diagnostic performance remain as the independent predictors even in the multivariable analysis. In the figure 2, you can see that the combination of the ARAS preservation score and the simplified CHOP score showed the highest diagnostic performance in the AUC analysis. So we get a conclusion that the 99mTc-ECD SPECT help predict neurological recovery in OHCA patients, which aid further therapeutic decision. Also, we suppose the strength of ARAS score mainly lies in the unbiased interpretation between the physician, especially in the life-saving process, rush conditions, because many clinical data may lose in the rush conditions. So here's our presentation. Thank you for listening, and feel free to raise